So we can start.
Okay. Thank you very much. Very good afternoon, all of you. So I welcome you back on this Step N program, which is specially designed for our critical care nurses, particularly who are doing this IDCCN course and are going to appear for their exams next year. And this is a very important topic this afternoon that we are going to discuss. And this is all about the quality indicators in the ICU. When we work together in the ICU as a team, nurses, doctors, the critical care technicians and other ancillary staff, how good or how bad we are performing as a team is being seen with the help of certain indicators, certain benchmarks that has been set by various national as well as international bodies. So they help us to judge how good our ICU is performing. And when I say ICU performance, it means actually we are looking at the outcome of our patients, how our patients are doing, the critically ill patients who are getting admitted with us, and particularly the most vulnerable age patients, elderly patients who are with us with lots of comorbidities in the background, and how good or how bad they're doing in our ICU, because our work performance as a team is being judged with the help of certain indicators. And this afternoon, we are going to talk about those indicators. This is a very important topic that all of us should know. And it's, in fact, this is an important topic and this is a very favorite topic for examiners as well. And they will ask you questions on this topic. So with that prelude, I'll just hand over the session to Dr. Shivangi Mishra, and let me introduce her to you. She's a consultant in critical care medicine who is working at the Manipal Hospital in Whitefield in Bengaluru. And over to you, Dr. Mishra, and just enlighten us with today's session.
Hello.
Yes, ma'am. Ma'am, your voice is getting, it's breaking a little bit.
Hello.
Hello.
Hello. Yeah.
Ma'am, actually, your screen is freezed. Participant, please bear with us. Dr. Shivangi will be joining in some time.
Hello.
Yes, ma'am.
Yeah, I'm audible now.
Yes, ma'am, you're very much.
Sure.
If you can just share the slides.
Yeah, just a second. Hello.
Yes, ma'am.
Yeah. So good afternoon, everyone. Like Dr. Soutik said, we'll be discussing one of the most important topics when it comes to the care in intensive care unit. It is important from the perspective of doctors, nursing care management as well. This is something known as quality indicators in ICU. What are quality indicators? So the term quality indicators has been there for quite a long time, since when the concept of ICUs were not there. But a proper definition for quality indicators was given only in 2003 by Donabedian et al. He defined quality indicators as a specified quantitative measure of magnitude or frequency that specifies what is good or not. He basically classified the quality indicators as structure-based, process-based, or outcome-based indicators. Previously, what care used to be provided to patients was something known as best possible care. That is, whatever was possible best from the perspective of healthcare system or a physician was being provided. But the scenario has changed over time. Now, the family, the patient, they expect and they deserve something holistic care, something known as a total quality. That is a good care from all the perspectives. With regards to this, many societies have given their own guidelines, like European Society of Intensive Care Medicine, Indian Society of Critical Care Medicine, ANZICS, etc. European Society of Intensive Care Medicine have given 13 basic indicators. These, again, they have classified as structure-based, process-based, and outcome-based indicators. The structure-based indicator includes that the ICU is fulfilling whatever is the national requirement set up by the ESICM, or there is a 24-hour availability of a consultant level intensivist in the ICU, and there is an adverse event reporting system. Process indicators include that there's presence of multidisciplinary team rounds are there, a standardized handover procedure is there, a system of continuing medical education is there, and target bed occupancy rate is always kept below the threshold level. And the outcome indicators include the standardized mortality rate, ICU readmission rate within 48 hours of discharge, rate of central line associated bloodstream infection, unplanned endotracheal extubation, endotracheal reintubation rate within 48 hours, on the rate of ventilator associated pneumonia. However, among all these 13 indicators, ESICM, they removed 4 of the indicators. Those are in the red ones. That is the maintenance of continuing medical education, threshold level of bed occupancy rates, reintubation rate, and ventilator associated pneumonia. Why is that so? Basically, these factors, they don't have a very consistent definition, and standardizing these parameters becomes difficult. At the same time, conditions like ventilator associated pneumonia, it becomes difficult to, there are various definitions defined by various societies, and it might become difficult to diagnose. So keeping this in mind, these 4 parameters were removed and the remaining 9 were included as the core quality indicators. Now coming to what our Indian society has recommended. So basically, this whole lecture, we will be going ahead with whatever parameters and quality indicators our Indian Society of Critical Care Medicine executive guidelines has recommended. So ICCM has classified the quality indicators as outcome, process, infection related, communication related, human resource related, and safety related. So what are the outcome variables? Outcome variable can be either related to the mortality or the morbidity. What we normally call as a mortality rate is a basically crude mortality rate. crude mortality rate lacks ability to compare with the national standards and even compare with the set hospital or institutional standards as well. So there's something known as standardized mortality rate. Similarly, coming to morbidity, there are few indicators which specifically look after morbidity, which can indicate the outcome, especially of the institution per se or the ICU per se. These includes iatrogenic pneumothorax, acute renal failure, decubitus ulcer. Can anyone in the group tell me what do they understand by iatrogenic pneumothorax among the participants? Okay. Or acute renal failure? Okay, so we'll come to the what we understand from by these terms at a later after some time. So SMR or standardized mortality rate. What is SMR? SMR is basically when we compare our actual performance of the institution with the predicted performance. Actual performance here means the mortality rate of our institution, of our ICU, and predicted performance means what is the average mortality based on the national data, national and international data. So it is calculated as observed rate divided by risk adjusted expected rate into 100, where observed rate is actual death in ICU or institution, and risk adjusted expected rate is predicted death rate by predictive model. Now, what does this mean? Predictive death rate by predictive model. Various scoring systems have been defined, like Apache score, SAP score, modified physiological scoring system. So these scoring system, like for example, Apache score, it scores patient at the time of admission from up to a level of 71. Okay, and depending on the score which the patient gets, the patient is classified into various groups, and these various groups have their own predicted mortality. Like a patient with a score of somewhere around 65 might have a mortality rate of almost 100%. Similarly, a patient with a less score on, or a score of maybe 5 on Apache might have a very low mortality rate. So what is done is, if we calculate what is the mortality for each group of patients in the Apache scoring system and compare it with what is the expected mortality for the same group of patient based on the scoring system. And with that, we arrive at a score. So if the score is equal to 100, it means the hospital mortality rate and the expected mortality rate are the same. If more than 100 means hospital mortality rate is higher than expected mortality, and less than 100 means it's lower. However, it needs to be emphasized that standardized mortality rate, or for that matter, any parameter, should not be taken as a single parameter to base our judgment on the performance of the ICU. When we are deciding on the performance of the ICU, multiple parameters should be taken into consideration. So coming to our morbidity related indicators, what does it mean by iatrogenic pneumothorax? Iatrogenic pneumothorax is when pneumothorax is created by any process or procedure done in the hospital or the ICU. One of the most commonest cause of iatrogenic pneumothorax are like central line insertion. However, there can be other causes like surgical procedure related pneumothorax, or maybe ventilator or related iatrogenic injury, pressure injury, barotrauma causing pneumothorax. So, how is it calculated? It is the number of pneumothorax, iatrogenic pneumothorax divided by the total number of cases into 1,000. For each of these parameters, we set something known as a benchmark. Benchmark is what has been calculated keeping in mind the national and international data on the incidence of the specific parameter. For instance, in this case, the average mortality rate based on various data has been calculated. Average rate of iatrogenic pneumothorax based on the data has been 0.83 per 1,000 cases. So when we target a quality indicator, we should always try to keep a watch and assess and keep these quality indicators under those benchmark. Acute renal failure. What does it mean by acute renal failure? So I didn't get any answer from, would anyone still like to comment on what they understand from acute renal failure? Any of the attendees? Okay, so this is not the definition. Basically, acute renal failure normally is defined. There are many definitions for that using our urine output and the creatinine values. But when it comes to the quality indicator or use of acute renal failure as a quality indicator, we keep a watch for something known as severe acute renal failure, which according to our guidelines has been defined as new onset acute renal failure, either requiring renal replacement therapy or with a urine output less than 200 ml in 12 hours, or marked azotemia, that is burn more than 84 during the patient's ICU stay. How is it calculated? The number of patients who developed severe renal failure divided by the number of patients managed in ICU into 100. Presence of acute renal failure, new onset acute renal failure happening in ICU increases the mortality significantly, up to 60%. So our target should be to keep the instance of, keep a check on the instance of acute renal failure to less than 5 to 6%. What does it mean by decubitus ulcer? I'm sure many of our, at least the nursing staffs who are here, they would have seen the decubitus ulcer in their patients. Whenever there's any prolonged uninterrupted pressure over any of the components, what normally we think is decubitus ulcer is basically pressure ulcer, bed sore, that the patient is lying and the patient will develop a bed sore in the dependent area, that is the sacral area, the buttocks. However, it's not just the buttocks. Any pressure, bony prominence on which prolonged and uninterrupted pressure happens, it can cause a decubitus ulcer. It can be even seen in prone position. When we prone the position, we can see decubitus ulcer on the face, we can see decubitus on the chest, the breast, abdomen, everywhere. Or the bony prominence, the knees, the ankle, all these prominences can be seen in prone position, supine position as well. It doesn't have to be only your buttocks or the bed sore which you are seeing because of the pressure. Okay. So the decubitus ulcer is generally classified in 4 stages. That is stage 1 when there's any just superficial color change. Stage 2 when there's partial thickness skin loss. Stage 3 when there's a full thickness skin loss. And stage 4 when there is deep and extensive tissue damage, when it progresses up to the muscles and bones and tendons are visible. Okay, so the most common size still remains the hips and the buttocks. So how is it calculated? We calculate the total number of pressure ulcers divided by the number of cases into 1000. The target benchmark remains to keep the incidence of pressure ulcer less than 22 per 1000 cases. Now, coming to operational, or what is also known as process variables or process quality indicators. So the most common and our Indian society recommended process quality indicators include the length of stay, compliance to the protocol, and ICU readmission rate. Can anyone tell what do they understand by the ICU readmission rate? Okay, I think we'll come to that later. So what is length of stay? Normally what we understand when we see a patient is we see that suppose the patient has come on first of the month and patient is getting shifted to ward on 10th of the month. So we say that day 1 is first and day 10 is the 10th day of the month. However, because of the timing of admission, it becomes difficult to standardize. So the length of stay should always be calculated as total days and hours of midnight bed occupancy. That at the standard time of the day, that is at midnight, how many beds were occupied in the ICU. Okay. So length of stay can vary with multiple parameters. That is the nursing care, definitely the care, the medical care, nursing care, the discharge practices, or the mortality rates. At some places, discharge is preemptive discharge happens, or patient gets discharged or shifted to ward very quickly than the patient would have required. So these kind of factors, they can affect the length of stay of the patient. Generally, for calculation of length of stay, median should always be taken into consideration, because mean can get affected by outliers. What we mean by outliers is that some patient out of, suppose if our ICU is having 25 patient, one patient who will be very sick might stay for a month or so, or more than that. While there can be just some post-surgical or joint replacement case who has just come for a couple of hours or a day. So these kind of cases become outliers and they can affect our value. So we should use something known as median to calculate our length of stay. It is calculated by using the total occupied bed days at the midnight and divided by the total number of patients in the given time frame. It can be calculated either weekly or monthly or yearly basis. So our target remains to keep the length of stay less than 4 to 5 days in general ICU, though it can vary with different types of ICUs. What is readmission rate? Readmission to ICU is when a patient comes back to ICU within 24 hours of being shifted or transferred. If the patient is getting discharged or shifted to ward, if the patient gets readmitted, such patient gets readmitted, it will be considered as ICU readmission if the patient comes back within 24 hours. Readmission of patient to ICU significantly increases the mortality in the patient, and mortality goes up by even 10 times in such kind of patients. Readmission indicates that the most commonly that there was a premature decision was taken to shift the patient out. However, there can be other factors, some new development, new or completely new pathology which can be the cause of the readmission as well. It is calculated by the number of readmitted patients divided by the total number of patients managed in ICU into 100. Our target remains to keep the ICU readmission rate within 5 to 6%. What does it mean by compliance to protocol? So all the ICUs should stick to something known as care bundles, like COTI bundles, CLAPC, CRBSI, bloodstream infection care bundles, and VAP bundles. Also, all the ICUs, they stick to some selected guidelines, be it national or international guidelines. They try to maintain their practices in compliance to some of the certain guidelines. So it becomes very important to keep a watch whether whatever guidelines or the bundles which have been set to be practiced in the ICU, whether it is being maintained or not. So we check how many times these kind of bundles are followed and how many times which is expected to follow. Okay, divide into 100. And ideally, the compliance to the set protocol should be more than 90%, ideally 100%. What does it mean by error or safety? So when planned action, there's a failure of the planned action to be completed as we had planned or intended, or a wrong plan was used to achieve the aim, then it can be labeled as error or safety issue. So what are our error quality indicators? Patient fall rate, medication error, adverse events or error rate, needle injury rate, and re-intubation rate. I will seriously like our attendees to participate in this. What do you all understand by patient fall rate? What do you understand by patient fall? You can comment as well if you don't want to speak out. Or if someone wants, you can unmute your speaker and answer. Anyone would like to volunteer? What do you understand by patient fall? Okay. So the common understanding from patient fall is that patient falls from bed. But that is not the only reason or the only criteria to be included as patient fall. Patient fall is an untoward event which results the patient in coming to rest unintentionally on the ground or another lower surface. It can be accidental, anticipated physiological, or unanticipated physiological. What does it mean by these? Accidental, yes. If the patient is on the bed, the side rails are not up and the patient falls down, can be labeled as accidental. But what does it mean by anticipated physiological or unanticipated physiological? So suppose there's a patient who was fine. The patient goes to washroom and had a fall. That can be included as unanticipated physiological. Maybe the patient had stroke, maybe the patient had seizure or anything. Anticipated physiological. If the patient is having hypoglycemia and the patient gets up from the bed and starts walking and the patient has a fall. that is anticipated physiological. So all such scenarios have to be included in patient fall rate. It is calculated as the total number of falls divided by the number of bed days into 1000, with our target to keep the patient fall rate less than 8 to 9 per 1000 bed days. Medication error. What can be the source of medication error? How does a medication error happens? It can be that the doctor has given the wrong prescription, or the doctor has given prescription for some other patient and that has been administered to some other patient. Or the doctor has given something known as LASA. That is, I think you all the staff must be aware of look-alike, sound-alike drugs. So if something like that has been administered, or there has been, doctor has said something, but it was not a written prescription, it was not a written order. The doctor said something, the staff understood something, or it can be not just staff. Suppose the consultant says something, the resident understands something else, or even the mode of administration, not just the drug itself, how the drug is supposed to be administered. So all these things can amount to something known as medication error. Precautions like name alert, tags for LASA medication, compliance with written down practices for medication error should always be practiced in the ICU. However, to keep a watch whether such practices are there or not, we need to have a medication error quality indicator. Medication error, more than 78% of serious medical errors happening in ICU are because of medication errors itself. The rate of the medication error can be calculated by the number of errors happening by the total number of bed days into 1000. So the incidence of medication error varies from 1 to almost 950 per 1000 patient days in adult ICU. Adverse event. What do you all understand by adverse event? So adverse event can be related to anything. These are like errors in treatment, or error in procedure, or ordering or carrying out medication orders, or errors in communication, or failure to take precaution to follow protocols. So basically, when suppose someone is going to give handover, the person who is giving handover to the next person, be it the staff or the doctors, they have forgotten to give handover of something very significant for the patient care. That can amount as an adverse event. Failure to follow and the protocols which have been set, or there has been any line related issues have happened, accidental pulling out of lines have happened, or some other than the medication dosing and communication related issue, any other issue has happened with the medication. All these can be included in adverse event. It has been reported that almost all the patients admitted in ICU, they suffer one or the other way with adverse event. And in more than 50% of the cases, the adverse event can be preventable. Adverse event can be calculated as the number of errors by the number of bed days into 1000. So it can be, if there's just for adverse event, our benchmark remains to keep it less than 80 per 1000 bed days. In case of preventable adverse event, it's less than 36 per 1000 bed days. Or if it's just a serious error, it should be less than 150 per 1000 bed days. Needle stick injury. What you'll understand by needle stick injury? Okay, we are having very few volunteers here. So, a common understanding for needle stick injury is that it happens because of hollow bore needle. Okay, that's what most of us, we think that if we have got pricked only by a hollow bore needle, then it is a needle stick injury. Otherwise, we don't need to worry. However, it's not like that. Needle stick injury is defined, this is a CDC definition, that any penetrating stab wound from a needle or other sharp objects that may or may not be associated with exposure to blood or other body fluids. Okay, so it can be because of faulty handling of needle or the suture material or syringe, or while recapping the needle, which is one of the most common source of needle stick injury, or while disposing as well. If it's not been disposed, not just to us, to the housekeeping as well, it becomes a source of the needle stick injury. However, yes, the contaminated hollow bore needle accounts for more than 63% of needle stick injury. The incidence of needle stick injury is calculated per 10,000 venipunctures. And we should try to keep incidence of needle stick injury to around 0, at least less than 1 per 10,000 venipunctures. What does it mean by re-intubation rate? So this is what I would like to mention. I just saw a comment in the chat box as well. Someone has asked 48 hours of readmission. So the difference I want you all to understand, if we are discussing, when we are discussing about readmission, it should be less than 24 hours. And when we are talking about re-intubation, it is within 48 hours of extubation. It can be a planned or unplanned extubation. When it happens after a planned extubation, after a planned extubation, most probably the cause of reintubation becomes that the patient was extubated prematurely. However, accidental extubation is one of the most common cause of reintubation. Reintubation significantly increases the incidence of nosocomial pneumonia, mortality, prolongs the length of hospital stay. It is calculated by the number of patients reintubated divided by the number of patients extubated into 100. And the target should be to keep the incidence of reintubation less than 12%. Infection control quality indicators. I think most of you all will be aware of these variables, that is ventilator-associated pneumonia, bloodstream infection, urinary tract infection rate. So what is ventilator-associated pneumonia? Ventilated patient, when they develop new opacity or they are fulfilling the criteria for VAP, it is known as ventilator-associated pneumonia. VAP is one of the, though we don't have significant Indian data, but taking international data, VAP is becoming one of the leading causes of mortality in hospitalized patient. Stands as the 8th common cause of mortality in the hospitalized patient in US. And it causes a significant burden on the significant financial burden and healthcare burden. It increases the hospital length of stay, increases the mortality rate. The crude mortality rate increases by almost 50% in cases of VAP. So it's calculated by the number of patients developing VAP into 1,000 days divided by the number of patients mechanically ventilated with endotracheal tube. How do we identify VAP? That is by the presence of radiological signs, that is the 2 serial chest X-ray should be done, which should be having at least one of these. That is, the patient can be having some cavity or some new infiltrate or infiltrates which are increasing in size, or there's presence of consolidation. Or along with the radiological sign, patient should be having clinical signs, that is at least one of the following, that is fever, leukopenia, or for adults more than 70 years, whether if there's any altered mental status without any other cause, and either one of these, that is there's a new change, any change in the sputum, either there's a new development of purulent sputum, or the change in whatever is existing purulent sputum, or the increase in amount of the secretions, or increase in suctioning requirement. All these things, these are small minor things, but they can be help us in identifying VAP very quickly. Or presence of any new onset of worsening cough, any abnormal bronchial sounds, or worsening of oxygenation, gas exchange. Any of these two plus fever, either fever or leukopenia or altered mental status in age more than 70. If any of these are present, these can be an indicator for ventilator-associated pneumonia. The benchmark for ventilator-associated pneumonia varies significantly among the type of ICUs. Okay, the reason, if you will slowly go, if you will go through these the benchmark days, that is the number of the incidence of ventilator-associated pneumonia divided by the incidence of the endotracheal intubation. If you'll see, the number is significantly varying. In burn unit, it is 10, while in pediatric medical unit, it's 2.1. Why is that so? Incidence in neurological units is 7.1, incidence in neurosurgical unit is 6.5, trauma is 9.3, burn is 10.7. Why is that so? Basically, these units, they require very prolonged ventilator. Burn patient, trauma patient, these kind of patient, they require very prolonged ventilator support. And such thing increases the incidence of VAP in developing in these patients. That's why in such kind of cases, the benchmark has been kept separately for every different type of the ICUs. What is bloodstream infection? Bloodstream infection is one of the major cause of nosocomial infection in ICU. It is basically infection developing, arising because related to central line insertion. Okay, it is calculated by the number of central line associated bloodstream infection into 1000 divided by number of central line days. Like we saw in the ventilator-associated pneumonia, similarly in bloodstream infection and urinary tract infection also, the benchmark, they vary with different kind of ICUs. The main reason being the trauma ICU, neurological, neurosurgical ICU. These ICUs, they require, the patients, they require prolonged ICU stay. And that increases the risk of developing bloodstream infection and COTI and VAP. Urinary tract infection, it is the most commonest cause of nosocomial infection. This is the incidence of urinary tract infection per 1000 catheterized days in patients catheterized in the unit, but not infected on the day of catheterization. So means when the patient has come and the patient, we have catheterized the patient, at that time patient was not having any urinary tract infection. So those patients are included in the calculation of the incidence of urinary tract infection. It is calculated number of urinary tract infection in 2000 divided by number of catheter days. Okay. Coming to the remaining variables, that is human resources and patient satisfaction. So the human resource variable quality indicator is basically the employee satisfaction. Employee can be anyone. It can be our on the nursing staff, other paramedical employees, or non-medical employees. All of them will be included for the survey of employee satisfaction. These quality indicators are surveys are basically used to assess such variables. Satisfaction of the level of staff working in the hospital or the ICU is taken into account. Generally, though there are very different type of surveys is there for and all the institution, they have their own setup standards to check the employee satisfaction. But one of the commonest which is used is a survey using 1 to 5 point scale, with 5 indicates highest level of satisfaction. The target remains to keep the employee satisfaction more than 4 at least. It helps in increasing the retention, that is the staff, they feel like staying in the hospital for a longer time, and the outcome of the staff also becomes better. And last is the consumer focus related variable. Basically, here what we check is how satisfied has been our patient. Survey based with feedback form and 10-point scale is taken. And the patient's opinion is taken with regards to multiple factors like the physician communication, nursing communication, cleanliness, noise, responsiveness, pain management. So factors like these. And these are the benchmark, what is our target, what we should keep, how much the patient should be satisfied with these specific points. So till now, whatever was discussed was what was recommended by Indian Society of Critical Care Medicine. We have already discussed what variables the European Society says. There have been many other variables. And even though Indian Society recommends, different hospitals have their own set of quality indicators as well, other than what is recommended. These are whatever has been recommended are the basic quality indicators. And even separate ICUs can have separate kind of variables to assess the quality. Like a cardiac care unit, it becomes very important to assess what is, has there been early administration of aspirin in acute coronary syndrome? Or what is has there been a quality indicator for early reperfusion techniques in STEMI patients? Or in cases with patient with breathing difficulty, risk of thromboembolism, or whether surgical intervention has been taken in case of traumatic brain injury. Has the patients are being started on enteral nutrition adequately or not, the nutrition the patients are receiving adequately or not, sedation is being administered adequately or not. In transplant ICUs, what is the organ donation rate of organ donation? So and general practices as well, like hand hygiene practices, all these things as well take part in assessing quality of the ICU. Sometimes they are used as quality indicators. Otherwise, at most of the places, they are used as an indicator to do audit and see how is the compliance with all these measures. Okay. So there's just a couple of questions I would like to see if anyone would like to answer. What is the most common cause? These are we have discussed in the talk. What is the most common cause of needle stick injury? Whether it's stab wound, scalpel wound, or hollow bore needle. Anyone would like to answer?
Listeners can unmute yourself and answer this question.
It's a very simple question. We have just discussed this. So.
Please raise your hand and we will unmute you. And someone has typed B in the chat box.
B. Okay. Okay. Anyone else would like to answer?
This is something that I'm sure that your infection control team, your hospital must be discussing with you every day. What needs to be done when there is an accidental needle stick injury? What are the steps that has to be followed? That you have to write an incidents report form, and then where you should go, what you should test. So this is something that is very important that all of you should know, not only for critical care nurses, but for all of us. So this is a very simple question which Dr. Shivangi has already covered. So if anybody else wants to come up with an answer, you can. Okay, Dr.
Okay,
Shivangi, please you give the answer because
Yeah.
we are running out of time.
Yeah. So I have already discussed. Basically, needle stick injury can be because of any of these. It can be any sharp object, contaminated, uncontaminated, causing injury can be a needle stick injury. But yes, the most common cause of needle stick injury still remains contaminated hollow bore needle. It incidence rate goes up to 60%. Most commonly, when you are recapping the needle, then you get the prick injury, needle stick injury from the hollow bore. Okay, fine. Just one more question. Yeah, which of these is a mortality indicator? Standardized mortality rate, iatrogenic pneumothorax, reintubation rate. Okay, anyone else would like to answer? I can see some answer in the chat box. Okay, I can see a B answer as well. So yeah. So a few of you who have answered it rightly, yes, it's standardized mortality rate. Like we had discussed, it is basically comparison of our own crude mortality with the existing standards, national, international data, using predictive models. This is the mortality indicator. Yeah, someone has answered iatrogenic pneumothorax. Iatrogenic pneumothorax is a morbidity indicator. That is when pneumothorax is happening because of any of the intervention happening in the hospital, be it a surgical intervention, non-surgical intervention like line insertions, or maybe just ventilator associated pneumothorax. Okay. Yeah. Thank you. Any doubts?
Thank you very much, Dr. Shivangi. It was such a nice and elaborate presentation, and I'm sure that our listeners will be benefited out of it. Once again, I'd like to highlight the point that this is a very important topic for you, both for your theory MCQ examination as well as for your Viva practical examination, because the examiners are very fond of asking you about the indicators in your ICU, and please do know about your own indicators, about your own percentages, how good your ICU is doing, because they might ask you about the incidence of CLABSI in your ICU, the incidence of VAP in your ICU. So know about these infection control indicators, because they are very important. And at the same time, I would like to say that know about the organisms as well. What are the organisms that you are actually growing in your backyard? For example, the ICU in which I work has the highest incidence of Enterobacteriaceae, particularly Klebsiella. So the multi-drug resistant Klebsiella are the ones which are actually bothering us more in patients maybe with VAP or other forms of infections. And next comes E. coli, and third may be the Acinetobacter. So we have been able to manage our Acinetobacter infections quite well, and that holds true even for the gram positives. Our incidence of MRSA has been less than 2% for last 1 year or so. So that's why the examiners might ask you about these incidence rates in your ICU as well. So know about your backyard as well very well. Talk to your infection control committee members so that you have an idea about these quality indicators and what are the organisms that they are picking up the most, the incidence, and how good or how bad you are doing. And as you talk to them, you'll get an idea about the compliance, how good or bad you are adhering to your protocols, particularly hand washing. When it comes to hand washing, that is very, very important in ICU, because that is perhaps one most important maneuver by which you can reduce the chances of cross infection in your ICU. Know about these indicators very well, because they are being asked both in your theory MCQs as well as the examiners can ask you in your practical. The mortality, the morbidity indicators, your reintubation rate, and know about your own data. That is most important. If you just name them well, that's very good that you know about these indicators, but do have an idea about the percentages in your own ICU, because the examiner, the external who will be visiting you at the time of your practical exam might ask you about your own incidence rates. So know about this as well. So with that, I think we have come to the end of this particular session. So once again, I'd like to thank Dr. Shivangi, who has taken out her time, and she has given a very good presentation. This is not a very common thing that we regularly discuss, but exam point of view, this is an important topic. Questions do come in both in theory as well as practical, as I told you. So this is a very nice presentation that you have done. Keeping our own ISCCM guideline as the benchmark, and that is the national guideline that we are following, because we all work in Indian ICUs. Our socioeconomic context is different than what they are facing there in the West, and we should focus more on Indian data rather than looking at Western data. And now with more and more multi-center studies which have been endorsed by ISCCM, which are coming up, we are now gradually developing our homegrown data. So that is very important. So we should have an idea about Indian data as well. So thank you very much. And I would like to thank everyone at this from ISCCM, the support team, who have enabled us to hold this discussion today. So with that, I would like to conclude today's session. Thank you very much, and study well.
Thank you.
The gods are watching on you. Thank you.
Thank you, sir. Thank you, ma'am.